So the PhD explored maternal anxiety and infant feeding from pregnancy to parenthood, and it had a large component of qualitative interviews with women longitudinally from the final trimester of pregnancy right the way through the postnatal period up until about 6 months, and then a number of different quantitative studies that kind of came off the back of the qualitative studies. The qualitative study was the big component of my PhD that really generated a lot of ideas around mental health and feeding and the relationships between the two of them. So since my PhD, I've kind of developed two strands to my work. So one focusing on measurement and screening of perinatal mental health conditions, because there's been a lot of problems in terms of how we measure the mental health of women, particularly in the perinatal period. And then the second strand of my work, which is infant feeding. So looking at relationships between perinatal mental health and feeding, bi-directional relationships, so, how mental health affects feeding practices, but also how feeding practices affect mental health. And also looking at some of the wider societal issues around infant feeding that play into these relationships between mental health and feeding. So the very first thing we did in the PhD was we did 2 reviews of the literature, looking at all of the existing literature in the area regarding anxiety and feeding. We did 2. We did one looking at prenatal anxiety and infant feeding, and one looking at postnatal anxiety and infant feeding. There were 6 studies in total in the prenatal one, just to show you how small the literature base is in this area. The postnatal one was bigger, but we had to include studies that looked at depression with anxiety as a feature of it. There were 33 studies in the postnatal one, but that's literally all of the literature all around the globe relating to anxiety and feeding. So we identified there was nothing out there, which led into the qualitative study to really explore with a group of women and following these women through from pregnancy to after birth, what was happening. And that gave us a lot of different ideas, 2 of which were the cross-sectional quantitative studies that I've just mentioned, which looked at the emotional and practical experiences of groups of women with varying feeding methods. So they were mirrored studies in that we used identical measures. So in terms of guilt and stigma, the sources of the guilt and stigma, we also looked at respect, satisfaction with healthcare professional support. Moving on from the qualitative research, we then wanted to do quantitative research using formal measures in order to test some of the predictions that had come out of the qual. And I set about looking for a measure of anxiety to use. But when I started to look at how these measures were being used with perinatal populations, came across a lot of problems. And then we delved a bit deeper. And actually, a lot of these measures that are being used in perinatal populations, they haven't even been validated in a perinatal population. So their psychometric abilities haven't been tested in a population of mothers. So there wasn't a single measure of anxiety that existed for the period after birth. There was pregnancy-specific anxiety measures that looked at things like fear of childbirth, fear of bearing a handicapped child, fear of changes in appearance during pregnancy, but nothing for after birth. So we used the qualitative data from the women, because we collected it at various time points in the postnatal period. So we created this huge bank of items. There was about 120 questions to start with, which is way too long to administer to a mother, to be honest with you, particularly just after birth. So we ran some pilot work with women to try and identify what the key anxieties were, to tap into the really predominant ones that mums were experiencing. And we ended up with a 51 item scale, which we validated as part of my PhD in a perinatal population of women with infants between birth and 6 months. And we found that this measure provided a total score of anxiety, but it also had 4 subscales being groups of related anxieties. So we found a subscale around competence and attachment anxieties. The next subscale was infant safety and welfare anxieties. The third one was routine infant care anxieties. And then the final one was broader, and that was around adjustment to motherhood. And this measure, because it was like the only one out there, it got a lot of interest, like really, really quickly. Like we were really surprised. So it was published in 2016. We're now in 2021, and it's being used, translated or validated in over 55 research teams across 30 countries. And those 4 subscales hold constant across every different country it's been validated in, which indicates, as you've just said, that these constructs are universal. So certain items aren't applicable in certain countries, but the other items that comprise the subscale still held constant. So there's still that kind of pattern, that structure of anxiety that seems to be, I could tentatively say, universal across contexts and cultures. One of the things that we found, which hadn't really been observed in the literature previously, was that the large majority of my sample prenatally all intended to breastfeed and all had quite strong views about wanting to breastfeed and for how long they wanted to breastfeed for. And then when we got into the postnatal period with the same cohort of women, we found that many of these women weren't able to meet their prenatal feeding intentions. And we found that for those that had particularly strong desires to breastfeed, these were the women that tended to fare worst emotionally when breastfeeding didn't go as planned for them. And we found a whole array of negative emotional experience occurring as a result of not meeting feeding intentions. So variables that weren't actually intended to be a core component of my PhD to start with. So things like guilt, stigma, defense around feeding method, feeling ashamed, and feeling unsupported by health professionals, not feeling respected by health professionals. Women, the whole like kind of the take-home message from that blog was that women feel bad either way, and it's really not something that women should feel bad about. So which then leads into the next bigger question, I guess, why? So there's a lot of inconsistencies in the literature around these different emotions. For this particular study, we defined guilt as a negative emotion occurring internally, and we defined stigma as feeling a negative emotion from an external source. I think the transition to parenthood is uniquely stressful. I think there's a moral prism across all of parenting that extends to whether we work or we don't work, where, you know, whether we stay at home with our babies or not, whether we breastfeed or not. There are so many different debates that bring around parenting guilt, shame, stigma. So I don't think it's unique to feeding. I think it's a problem that exists across parenting. How you're observed, how you're judged. And I think pregnancy and childbirth and parenting has become very medicalised, which is where some of the problem comes from. I think particularly with feeding, breastfeeding is portrayed to women as, well, from health professionals as beneficial for infant health. So the nutritional benefits of breast milk are widely spread across women, but not enough is provided to women about the challenges associated with breastfeeding. I think all too often we sell the benefits without giving women realistic expectations of what breastfeeding is actually like. So we often set women up to fail because we don't want to cut them off. I think there's a fine balance between putting a woman off and being realistic. The way that we don't talk about common challenges associated with breastfeeding, it's almost like women aren't educated enough to hear it. They're not educated enough to be able to understand those challenges. So we can't talk about those. We must talk about how easy it is, how natural it is, how you must do it to 6 months, and it's got all these different health benefits for your baby. But we can't talk to them about the hard bits because they won't do it then. So I think it's kind of ignoring women's autonomy in a sense. More consideration needs to be given to women's individual circumstances when we're thinking about feeding duration and feeding method. Some infants are just naturally more challenging than others. Things like, tongue tie, and all sorts of different individual level problems. But then you've also got wider factors that influence breastfeeding behaviour that are beyond maternal control to start with. The workplace environment for breastfeeding, how well supported they've been in the hospital, in the community, how much exposure to formula advertising they've had. There's so many different factors that influence breastfeeding behaviour, some of which are individual level, but a lot of which aren't even within maternal control. It's starting a race at totally different points, isn't it, for some women? And it's not fair, and it needs to be more individualised in nature for each woman. And I don't understand why we're not at a point in society where a health professional can sit down with a mother and say, what would you like out of your infant feeding journey? And I imagine that if we offered that level of autonomy to women and worked with them with their own wishes, I think we'd see more continued breastfeeding if we did, rather than this blanket message. And what's even worse is that for those women who, as you say, we look on paper and you think you've got every risk factor going against you not to breastfeed, we're then not offering these women formula feeding, advice, information, support. So the women that we know are most likely not to breastfeed also don't know how to make up a feed. They don't know how to store formula safely. They have to ask, how do I use this? How do I make up a feed? Or they have to rely on the back of a tin in order to do that. So the very women that we know are less likely to breastfeed, we're not offering alternative feeding information so they can feed safely. So it feels like if you're not getting that fundamental right, I'm not getting that fundamental right according to guidance, according to what everyone's been saying to me all the way through my pregnancy. Everyone's been telling me that it's natural and it's easy and I can do it and I'm doing the best thing for my baby, but actually I can't do this fundamental. I feel like I can't. That sets women up for terrible emotional issues from the offset. And I think it feeds into other areas of parenting in terms of efficacy. I couldn't manage this. How can I manage that? So I think it has a knock-on effect in terms of other areas of parenting as well. A few things, I think we've got absolutely appalling exclusive breastfeeding rates in this country, and I think that the way that we're currently going about promoting and supporting breastfeeding, it isn't working. Our rates have stagnated. We've not seen any improvement across the last 10-15 years at all, and it's not just the case in the UK, it's across other high income contexts as well, which indicates that the way that we're going about things just isn't working. So I think we're focusing too much on the wrong area. I think if we can support women to feel good about how they parent, then we'll inherently get better outcomes for things like feeding, but also for in other areas of parenting as well. And I think we'll have an improved mother-infant relationships. And as you say, less of this fraughtness, less of this strained feeling like they can't achieve in any area. So I think by starting with maternal well-being, we'll see improvements in all of the areas that the baby-friendly initiative and the medical profession want to see in terms of infant health outcomes. I just think we're focusing on the wrong problem